Hello, and welcome to the Alabama Public Health Training Network. I'm Bill Kennedy with the Alabama Department of Public Health. Thank you for joining us today for our program, Addressing the Needs of Older Adults in the Age of COVID-19. If you have a question about anything being discussed today, please email us during our broadcast. The email address is on your screen now and will appear again later in the program. Also, the handouts and evaluations are available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for this program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. If you're watching this program on demand and want to receive a social work CE certificate, you will need to complete the social work test and send it in, along with the sign-in sheet and evaluation. If you're watching this program live, there is no social work test required. For social workers, if you're watching this program live, it does qualify for classroom hours. If you're watching on demand, it is considered non-classroom hours. Before we get started, I'd like to introduce our presenter today. Our presenter is James L. Sacco, Jim Sacco. Jim is not a stranger to us. He's done a lot of different trainings for us in the past. We're ecstatic that he's back with us. He's a consultant here with the Alabama Department of Public Health. And we've been looking for some opportunities for some training during this COVID time. A lot of our conferences, other trainings have been canceled or put on hold or delayed. And so we were looking for some opportunities. We reached out to Jim, and he had some trainings that he had been working on. And so we're really excited about this opportunity. And so this is the first of a series of 4 trainings that we're doing with Jim Sacco. And so all of them are going to be talking about COVID-19 and in different populations. So we look forward to that. And with that said, welcome, James. Welcome, Jim. I know you have a lot of important information to cover today. So why don't we go ahead and get started with your presentation?
That's great, Bill. Thank you very much. Good morning, everybody. Apparently, there have been some technology issues with the internet, and so I hope people are here and found their way in. It's my pleasure to be asked back for this very hard conversation. I want to acknowledge at the front end that we are all in the middle of trying to figure out what it is we do in the age of COVID-19. Normally, when I do a talk, I look for evidence-based interventions and peer-reviewed journals. And what strikes me is that we are building this thing while we're in process. We are building this, I was going to say airplane, feels more like a rocket ship took off in mid-March, and we are still trying to figure out what to do. I want to acknowledge that, unlike a number of things that we deal with, COVID-19 is not something that's happening over there, that I don't think any of us are removed from this. And so as we begin this conversation, I just want to acknowledge that I know we've got people who have been through their own illness, certainly all of us who've been afraid about contracting COVID-19, many people who've had people we care about affected by COVID. And I'm also aware that they're employees of ADPH who've lost family to the pandemic. And I want to start by just acknowledging the toll this has taken on all of us, and especially to those people who've lost family. My sympathies as we start to tease out how we continue to cope, because I wish I could say that this was over. In my mind, I think we're seeing some declines in some places, but I think we're in the middle of a marathon until there's a vaccine, and I've got no idea when that will be. So that's my name. I'm a social worker based in Asheville, North Carolina. I have been involved in ADPH, a number of different things, good friends in the HIV side, STD side years ago. I worked a long time with Annie Vosel in family planning webinars. I've been in that many times down there in Montgomery. I'm video casting from my basement. We talked about it, and I wasn't quite ready to travel, and we weren't quite sure, and so they're zooming me in. So anyway, this program, I guess it feels important to say, is sponsored by the Alabama Wise Woman program. If you don't know about Wise Woman, find somebody in your county that works in breast and cervical cancer prevention. The breast and cervical cancer prevention has some resources from CDC to help with chronic disease prevention among participants of a certain age in the breast cervical prevention program. And so big shout out to Rhonda and all the good people in the Wise Woman program. So we're going to talk about, in this meeting, we're going to talk about sort of what the needs are for older adults. And obviously, given the burden of disease, a huge part of our work has to be what are the needs of older adults in this challenge. What I would say is that the next series we're going to talk about unique issues for people with substance use disorder, some of the unique issues for people living with HIV, and the fourth series in this series in late July is going to be an emphasis on self-care, how those of us trying to cope, just our needs as caregivers. And so I'm again just delighted when they asked would I help with these, because I think we're all in need of guidance. I just think to pause for an hour and kind of think about what's good practice and what do we know so far. Again, I think this thing is moving. We're developing interventions while we're moving. So that's what we're going to do. We're going to talk about addressing the psychosocial needs, talk about some particular stressors that have occurred as a result of the onset of COVID-19. I think it's really important that we talk about depression. Obviously, among the most important psychosocial reactions to COVID-19, to the steps associated with protecting people, the physical distancing that has been being practiced, should be practiced, just what happens to older adults as they're cut off from some of the social activities. And then most importantly, probably, how do we support older adults as we go through this? So this is the first question I want to put out, and Bill's manning the emails. And so that's the email address there at the bottom, the ADPH email line. I wish this could be a conversation. I wish we were all in a live training room. I miss being face-to-face with trainees and sharing a box of donuts and meeting in a classroom. So in lieu of that, I was hoping people could offer your observations. So two questions, if you've got any observations. What do you see happening among the older adults that you serve? I guess I'm speaking specifically to people who work with this population, or for those who have aging parents or older adults that you care for, your neighbors, your friends, people at church. What do you see happening in their lives? What do you see as their unmet needs in light of COVID-19? And then the second really important thing, if you've got either or both of these, if you go ahead and log into your email and send Bill and the guys in the control booth are going to monitor these. I'll stop in about 15 minutes and check on any input, but either what you see happening, what unmet needs, or are there things you've found that are helping older adults? One of the things that I like to say is I'm not the only person with brains on this call. Lots and lots of us have experienced. Many of you have found things that have been helpful. Again, tending to the needs of your patients, your neighbors, your family members. And so if you've got any observations or any suggestions, those would be super helpful. We're going to share those in about 10 minutes. Bill's monitoring that website. So why are we here? Obviously, we are here because the reason we started with this is because of the disease burden, that in fact, if we look at who dies from COVID-19, the actual burden of deaths is happening among individuals in this country. I use U.S. data, but it's the same everywhere. The bottom line is the fatality of COVID-19 is happening with people over 65. There are charts that say sort of here's the likelihood of people in their 30s, 40s, 50s. Once you get in the 60s and once you get in the 80s, I've seen figures that suggest 15 to 20% fatality for people over 80. So it is a very, very serious. It's not unlike other diseases. The burden to the elderly during flu season. I'm mincing my words because I don't want to use the phrase "this is like flu" because this is not like flu. And anybody that's had COVID or loved anybody with COVID knows this is not the flu. However, when we see seasonal virus, what we see is the disproportionate impact of people with underlying immune suppression, elderly, people with chronic disease. And so in many ways, COVID-19 aligns with mortality patterns of other viral illnesses. In some care settings, infection rates are approaching 30%. What's happened in a setting like a nursing home, like assisted living, is an infection coupled with the living conditions and other chronic health conditions. So when we unravel the vulnerability to COVID-19, we're talking about is diabetes, COPD, certainly anything respiratory, cardiovascular disease, and the idea that vulnerability plus communal living. I mean, we've seen. I'm thinking our earliest hotspot was Seattle, and in Seattle, it took off in nursing homes, and what happened is we saw just enormous spread. Again, the factors outlined there. So what I want to do is kind of sort of think about what do we do, and I'm sort of teasing out what are the cognitive needs, what are the practical needs, what are the emotional psychosocial needs. So as I go through the rest of the talk, what I'm going to ask us to do collectively is kind of think about how do we help with people's understanding, gathering information, taking in health information. How do we help with safety issues and other practical needs? And then how do we help with the psychosocial support? So back to a social work model, nursing model, biopsychosocial is what I'm trying to accomplish here. And again, laying out these questions about cognition. As I think about what to assess in our older adult population, it feels really important that we kind of try to understand what are people able to take in. My parents both lived to be in their early 90s, and were in a care facility for the last 5 years of their lives. So I had lots of opportunity to observe older adults. And what I found is there was lots and lots of cognitive failure around them. And granted, they were in assisted living, not independent. But of those people who weren't identified as having cognitive, you'd be having a conversation. And if you work with the older population, you're having a conversation going, oh, we're doing great. She's tracking great. And we're talking about the president. And then she says, well, Eleanor Roosevelt, on the other hand, I don't like as much. You're going to go, well, she's still talking about Eleanor Roosevelt. Maybe her cognitive is not. So part of what I think is really important, because we're trying to do disease prevention management, is really understanding what your older adults are going to take in. So have we conveyed, are they able to comprehend the risk and the protective factors? So in other words, do they understand hand washing, masks, physical distancing? Do they understand the use of sanitizer? All of those kind of basic disease prevention, are those in place? And if not, how do you support somebody increasing their ability to avoid transmission and practice the things we know how to do? It's good news. It's not changed that much since we started. It is hand washing. It is masks if you're less than 6 feet away from people. It is sanitizing your hands. It is social distance. I mean, it is those factors. And I think being extra cautious around older adults, making sure they understand and practice. Most people I know who are caring for people over 70 are using very stringent social distancing, which just makes good sense. At this point, I can understand people saying we're not going to go see Mama yet, or we're going to stay 6 feet away and have a visit. Those folks I know who've breached that are kind of still having picnics on the lawn, and again, if I had a loved one in her 80s, I would be super cautious again because of the vulnerability of disease. So the other important thing for us to assess is what's the increase in self-care and caring for others going to be as a result of our cutting off. What I'm thinking about as a caregiver, I know many people stop by mama's home on the way home from the health department. You do your shift and do your second shift with mama and daddy and bring them groceries and make sure they're safe and make sure they're taking their meds or whatever, you know, in the age, particularly for those folks who are not in care facilities. Now, daughter and son used to stop by weekly or daily, or grandchildren used to stop by. In the absence of that, the burden of more care for self, or grandma taking care of Papa, and what are the unique needs that emerge? So just, is there a different care burden, and are they able to respond to those needs? I'm thinking about cooking, cleaning, medication, safety issues, all kinds of things that maybe caregivers have done for them, family have done for them, that in the absence of caregivers coming by or changing the pattern, patients may need to do themselves. So the great news in terms of assessment is we've got cognitive assessments. We've got some great help from the Alzheimer's Association, and I've got a SAMHSA website down there as well. The tools to assess cognition are really fairly similar. Orienting people to day and day. Can you tell me the day and day is an important clue about cognition. Many tests of cognitive ability involve word recall. I'm going to read 4 words. I'm going to read 5 words. Read words in a row, and then I'm going to read you 5 words. You're going to tell me back those 5 words: cat, clock, bell, whistle, whatever. And that a patient's ability to do that word recall is a clue to us about how they're doing cognitively. And the last sort of standard test, and I'm really generalizing, there are multiple different tests of older adult cognition, is draw a clock for us. Draw 7 o'clock, draw 3 o'clock. And the ability to draw a clock is another measure of cognitive functioning. So again, more tools available at both of those websites. So what do we do about cognitive impairment? If you're sensing it, or if you know, and let me just say, my own experience with my folks is, with them, it happened sort of progressed gradually, and because I was in regular contact, it took an event. We had kind of a crisis, and it was like, wow, mom's in really bad shape. My mom really was the first one, and so it may be that this is a time of people realizing, maybe shining a light on cognitive impairment for the first time. People saying, "Wow, they're in worse shape, mother or dad, family member, aunt, uncle, in worse shape." So, what do we do if we realize there's some cognitive impairment? The first is to increase check-ins, and that doesn't mean stopping by. Again, what I don't have are hard and fast rules. If you've isolated, certainly we know if there's been a possible exposure, you want to wait 14 days before you check in person. Again, if you are out in public and checking on older adults, you got to decide for yourself what level of physical distance you want to create. I think what's important is there are ways by phone and Zoom and Facebook Live and all these other electronic tools to check in with mom. We know we've got older adults who've learned what their smartphone can do, who've learned how to punch a thing, get a video call, who've learned to watch graduations and other things on their tablet, on their phone, on their computer. And so if you're aware of the problem, whether you're physically checking more or finding alternative technological ways, just checking in more often, again, safety, food, all those things. Good old memory tools. Those people who've worked with aging adults know that they've got all kinds of good ways to orient people, setting their pills up once a week, signs that indicate, think about acute care hospital settings. There's always, here's your nurse, and here's the day, and here's who you are, and calendars, all those all those kinds of clues, big clues. I'm barely in my 60s. I could almost use those reminders myself. What day? Big numbers on a clock, but sort of how do you build those in? Remembering diet and hydration. One of the things that happens sometimes as cognitive functioning falters is people forget to eat or don't eat well. There's a change in older adults' taste buds, and for a lot of older adults, what tastes good is sweets. That the last taste bud to go apparently is sweets, and so you got people that pick at their Salisbury steak and pick at their mashed potatoes, but bring out that bowl of ice cream and they're on it. Certainly, that was my mother. She picked at her supper until dessert came, and she was first in line, often helped Daddy with the rest of his. So, are your older adults eating right, staying hydrated? What can they do about physical activity? And again, as older adults have gone to more physical distancing, are they walking in the neighborhood as they did, or have they had to alter how much activity? What can you do to keep them as active as possible and practice the infection control that's right for them? And again, what we don't have, what I don't think anybody has, is here's exactly how much physical contact older adults should have. Again, there's this really clear black and white sort of, if I've had a recent exposure, possible exposure at work or just out in the world, then I'm going to socially, physically isolate for 14 days from everybody, and certainly from my older adult parents, loved ones. Beyond that, what level of contact, how often, everybody's finding their way. And so I just think my own take for my parents, were they living, as I would be really conservative. I've got neighbors across the street who I've got 2 4-year-old twins, and grandma and grandpa come sit on a picnic table and the kids are 6 feet away, and we're 3 months into this. My neighbors are still thinking, with twins and parents easily in their 70s, we're going to keep everybody 6 feet apart for now. And I think there's an argument to be made to be conservative, particularly because of the seriousness of infection with young people. Encouraging mental stimulation where you can. Can you get them crossword puzzle? Can you get your older adults crossword puzzles reading? What can you do to keep their brain going, keep them just off the television and the whatever else? I think it's also important, as you're teasing out cognitive impairment, there's a way in which depression in older adults can mimic cognitive difficulty and or other psychological stressors. And so just being mindful to make sure you understand what's going on so that you don't misjudge and assume a cognitive problem when there's a need for psychosocial support or somebody who can help. So infection control, as a social worker, is a little beyond my thing. I've talked about most of this: physical distance, hand washing, shelter in place. Again, we've gone through in Alabama. I know we're more liberal than we are here in North Carolina in terms of guidance on shelter. Again, I think what is clear from the CDC side is, if anybody, I've said this several times, if anybody's had a possible exposure, completely walling off for 14 days while you determine if there are symptoms, if there's been any contagion. That self-isolation is critical. So as we continue this vein of what we need to assess with older adults, sort of issues of safety come to mind. The most important thing I think to think about always with older adults is risk of falls. When we look at causes of injury for older adults, cause of other physical decline, it's the prevalence of falls in older adults that's really hugely problematic, and the most prevalent problem in terms of injury for young people, for older adults. And often that thing, many of you know, that starts the cycle of broken hip and COPD and other problems. So what are the fall risks? And again, what I'm thinking about is, if you aren't there to watch, sort of, are they keeping the right footwear? Are they, just looking around the apartment differently, looking around the house differently? Because particularly if you're not checking as often, to think critically through the lens of, well, there's that obstacle there that let's just take an extra step and move that obstacle, because that's the walkway between the bathroom and the bed. There's no need to have that there again, particularly because we may be checking less frequently on older adults. Talked about nutrition and hydration, but just to acknowledge the complications, especially of becoming dehydrated, are enormous for older adults, leading into urinary tract infection, all sorts of really serious health stuff. And for whatever reason, it's not uncommon that older adults kind of forget to drink. Again, not to beat a drum, but my mother in particular really didn't have much interest, and so every meal we had to say, drink something. What about medications? I'll make a connection to that first bullet. The biggest problem with falls is over medication. And so I said get mama's pills in the jar, but also make sure the pills aren't leading to fall risk. And what we know clearly is any seniors who are prescribed benzodiazepines, synthetic opiates, really are vulnerable to falls. And there's a real, the CDC guidance on falls prevention really paints a grim picture of use of opiates for pain, or any benzodiazepines for seniors because of the fall risk. So I'm not a prescriber. I can't tell people what to prescribe or not. But again, if you look at the data on falls, medication, particular medications are create a vulnerability to falls. And again, sort of making sure. And then are medications being taken properly on time? Are they being misused? Are your loved ones able, your older adults able to care for themselves? And what about their financial affairs? The other, I didn't know where to lump this up, put it under safety, but we've seen, some scams where, I'm gonna help you. Here's COVID insurance, or here's a COVID something. And so the idea that people are scamming, and always the prime target of scams, people over 70, over 65. And so just kind of being mindful. Again, we all know to check mom and daddy's checkbook if you're in a facility caring for older adults, to make sure their cash and jewelry is safe, but sort of doubling up in this stressful time. And again, as people are scamming, being sure that your older adults don't fall for anything. So fall prevention, as I said, mops, mids, obstacle footwear. You got to love those socks with rubber pads as the important way. Reminders about food, help with food prep and delivery. Again, you don't even have to be there necessarily. Here in Asheville, we've got all kinds of hands-free delivery of groceries and food. People are dropping soup off on their neighbors. I had a neighbor who was isolated. Our neighbor across the alley was isolated much of the winter because of her age and some other health problems. We'd be bringing some food, no hugging and no nothing. We'd say it's on your step, and go ahead and take care of that. Coaching around activities of daily living. Big caps are with respect. I just want to acknowledge that once you start to exert more influence in the lives of older adults, whether they're your family or whether they're patients that you're caring for, there's a dance to do between remaining respectful, helping people remain in charge of their own life, and gently asking if you can't help. Sometimes there's a pride that goes along with losing functioning, and you're going to have a senior say, I can do my own shower, I can do my own whatever, and sort of this dance of needing help, but stubbornly saying I don't need that help is something that we just need to be mindful of. And then monitor business affairs. One of the things that families do is they do the banking for mom and dad. They track the ATM cards, lock up things, but monitor those affairs. And if you haven't done that yet, or if you're working with older adults and family hasn't stepped in, it could be a time, especially if there's less physical contact. Again, people used to go on Saturday and go through the checkbook, make sure that nothing was funny. It may be time to say, you know what, let's get everything online. I'm going to monitor any activity, make sure mom and daddy don't make a mistake. So I'm going to catch my breath, get a drink of water. Bill, I asked our experts, what they're seeing among older adults and any interventions. What have you heard in the email? Anything you've heard?
I have. We've had several emails that came in, so that's
Great.
good to see. That means folks are watching. We're excited about that.
Great.
One of the first ones that came in said, I've been helping my parents. They're on hospice care, and I've been helping them connect with others through Facebook. And now they know how to do Facebook Live group chats, and so they've been able to connect with folks that way. I had another one that said, loved ones in the nursing homes, they want the attention of family, but they're lonely, concerns about their health, preventing the spread, and lack of visitors. And in regard to helpful, just by staying in touch, by frequent phone calls, staying in touch with the nursing home staff for updates, scheduling visits as the nursing home permits them, those kinds of things. And a couple more said that they found that their family's scared to go out, and so they're missing that socialization, and they're not very comfortable with the technology. Some of them just don't like getting on, seeing themselves, in a camera or something like that. Others, someone said that nowhere to go, and so they've lost track of days, and that's led to we're in the third month now of this, not bathing, not grooming. They don't have a reason to get up, a reason to get dressed, and so nobody's coming to visit them, or they're not going out shopping, or they're not going to church on Wednesday nights and on Sundays, and so just struggling with a reason to even do ADLs, to get dressed, to bathe, to brush their teeth, those kinds of things. And then I had another one. They're 50. They're in their 50s, and they have health issues also, and so they have fears of getting out, and so they're struggling with going to see their parents and taking care of their parents because of their own health issues, and so a lot of different things going on there with folks. A lot of it has to do with socialization. We're in the South. We like to get out and go places and see people and socialize.
Go have some sweet tea. Bill, let's go have some sweet tea and some pie, right? That's what I'm talking about.
Lunch on Sunday and Sunday school and church on Wednesday night, those kinds of things. But going shopping, my own in-laws, they have to have somewhere to go every day. They are busy and like to stay busy, and so whether it's shopping or whether it's to work out with the running or walking, those kinds of things, or volunteering, that's been a struggle for them, and so they're very active, and this has kind of slowed them down a little bit. Yeah.
I mean, these points are spot on. I think people talking about isolation, the nursing home story really hits at my heart. As I said, my parents were part of a care facility, and I checked in with the director once this started, and he is a good, ethical, loving chap, and he said, I've got a limit to one visitor per family, one member per resident, period. And so it means everybody else can't come. Well, yes, for the family who can't come, we're talking about cost benefit. And if I was running a facility, if I had a patient, a loved one at a facility, and I was thinking, do I want everybody bringing a birthday party with a dozen people? I'm with you, Bill. I want a caramel cake for my birthday so bad. I want 20 people singing to me. And I weighed those 20 people in a nursing home, and I've got to say no. I've got to say we're going to keep mom and daddy alive. And the hard choices, we're talking about in many of these questions, it's about hard choices and the risk of infection. My friends who said we're only in our 50s, but we've got chronic health conditions, we're staying home. Some part of me is saying, stay home. The reality is we're talking about seniors, but if you talk about, who with diabetes has had worse COVID, who with COPD has had worse COVID, regardless of age, there are certainly younger people with chronic health conditions who are more vulnerable. So I think what we do is we make those hard risk benefit things. As I said, I err on the side of safety, and We acknowledge the grieving that's associated with this. We're talking about the stress of grieving, seeing all the people that used to come on Sunday, grieving your church family. Bill said, what about church family? I'm missing my church. And yet I think, am I ready? We do all kinds of hugging and hand holding and whatever. I'm not ready to get in a crowded church and hold hands and hug. I'm just not there. In terms of interventions, I think technology is the answer. And I heard people say people are slower to come to technology. That's the reality. You know, the reality is I've been slow to come to a lot of technology. I can't wait to get rid of Zoom and Microsoft Teams. I'm all kinds of WebEx. I'm on all kinds of other things. But the risk benefit, I mean, I think this is a place to really step up. And if your relationship allows with your family to say, we want you to get up and get dressed, and we're going to call at 10 and make sure you've showered and dressed. That in other words, helping provide some structure. Somebody talked about losing track of the days. I promise you, I get that. A couple weeks ago, my spouse said, is it Saturday or is it Friday? And it was Tuesday. You know, I think we're all in that. But again, those tools to orient people, trying to bring people in line with social digital media where we can, trying to practice safe contact. Again, people, part of what we're coming into is what level of risk are we willing to live with. As I said, I know I'm not going to no concert or crowded nightclub, but am I willing to sit on the lawn 6 feet apart from my loved ones? And the answer for me is probably. But again, do I have chronic health conditions? What's their underlying immune system? How much other exposure have I had or those other people have had? I mean, again, we are making our way in a gray area because of the vulnerability of older people. I'm going to take a hard line and err on the side of being conservative. That being conservative to keep your older adults, to keep your mom and dad alive, and providing whatever support, including the psychosocial support, to say it is hard to stay home, Bill. To say to your in-laws, it is hard to stay home, and I know you miss running out to Dollar General every morning, but you being exposed to 30 other people might create a vulnerability. I'm not suggesting you fight, Bill, with your in-laws, but I'm saying for anybody who's in that position, people who want to go, I'm ready to go. I think we're all ready to go.
Hey, Jim.
Yes,
Jim, we have a couple of questions that have come in too. Please. From our Facebook Live.
Please.
The first one is, where are we with going to doctor's appointments with our parents? Currently in Alabama, that's not allowed. You have to, they have to go in alone. And so the question is, what's the benefit to them and their cognitive recognition and physical well-being? Yeah. I know when my mom was ill, I would go in with her because she was hearing every other word kind of deal. Yeah. She was just trying to deal with the disease at the time, and so she needed somebody there taking notes and somebody asking questions, and we're not able to do that right now.
But Bill, again, they may run me out of these webinars, but I'm going to take a hard line and say, if it's my practice, I'm going to just see Mama, but we're going to execute a signed consent to release information. I'm going to find that healthcare power of attorney, and I'm going to debrief you with what I said. If I'm smart, I'm going to run that meeting in Facebook Live. We're talking about running a meeting. Every practice I've ever been to has a laptop in the room. As an advocate for my family, I'm going to say, Mama's not going to get this. You're going to fire up a Zoom or either a Facebook Live, and I want to watch the interaction, and I want you to teach us both, and I want to see it on screen. I do think it's a very hard time, but every practice in Asheville still is saying patient only. And so again, I get it. And my parents were exactly the same. Mama didn't remember what she had for breakfast, much less what the doctor said. On the other hand, if you've got to think, part of what we're talking about here is managing what our parents need. I'm just going to say it. We're all public health people. The public health good of limiting how many people are in that nursing home, the public health good of limiting how many people in that medical practice. And I guess we're thinking about our own mom, but we got to think about the immunocompromised patient who comes next, and think about the good of everybody. And I'm going to say limiting the number of people, but for continuity of care and good medical practice, making sure that the healthcare power of attorney is in that loop in a different way than I would if you were sitting in the room with mama.
Hey, Jim, I had one more statement that came in. It had to talk about struggling to get supplies, struggling to get groceries, struggling to get their medications, struggling to find food. Cleaning supplies were the thing that everybody's struggling with, and of course that's a big deal for our senior adults as well. They're watching the TV, watching the news, and they're saying you need all these cleaning supplies, and yet they can't even go out, much less find them.
Right. Yeah, I mean, I think I wish I had that answer. I mean, I think where families can step in and help, but part of what happens with every social ill is it sort of shows the fabric of what's wrong in our society. And I would argue that as we hold up COVID-19, I'd like to believe it's showing the best of us. It's showing the best of us. But what's also happening is we're seeing some of the gaps and the enormous gaps in terms of what seniors have always needed and haven't gotten in. And again, there's no easy answer for that. I know I can speak to my social workers and say part of our calling as social workers is to advocate. And so I'm going to challenge at least the social workers who I know it's part of our mandate to be the one who raises our hand in staff meeting and says, we got hungry people, we're not addressing it. We got people that need services we're not providing. And we're the people that call other partners in town and say, hey, you need to step up. You delivering food to older adults, or you're delivering food for hospice patients. You got some older people not on hospice. You need to step up and do that work. But again, what we're talking about is a pandemic highlighting the vulnerability of older adults, and some of that is not fixable. Some of that just is for all of us, again, to advocate, and I would argue to vote and to talk to our elected representatives about the unmet needs of older adults that have been there. Some of this we're talking about has been there, and is just a light being shown on an existing problem. So it talked about psychosocial needs. None of this is new. I think there's a kind of free-floating grief. Bill, as you were talking about the questions and people's observations, what I started to feel was grief, just sadness and loss. And so I think depression and feelings associated with grief, sort of teasing out, is someone an anxious person? What we haven't talked about much is for people who are on the anxious or obsessive side, this thing is really a trigger. I know there's people on the webinar, on the video conference who are feeling your own need to clean and worry and sort of the, I call it the hamster wheel in my head, but there's a lot to be nervous about, and we don't have a lot of answers. There's still some gray area. And so for people who are prone to be anxious, this absence of social connectedness, when we asked for emails, that was the most pressing thing, and sort of how to live in a place with less social connectedness and not to minimize the sense of isolation, I think, is the challenge. Was there any pre-existing grief? We're talking about older adults as if they're in a bubble. This older adult also may have had a spouse that they've lost, likely has other friends that they've lost. If they're in a care facility, they've seen other patients that they've grown to care about. Again, in my own parents' life, they lost friends and siblings. They were in this facility 5 years, so they formed relationship in their assisted living with people that they eventually lost. And so all the grief that's there. The other reminder I've gotten, we'll go into this in the other webinars, is the idea that I'm starting to think of COVID-19 as a traumatic event, as a natural disaster. And I'm just inviting everybody to think about, are there ways that we know natural disasters? I know people in South Alabama have been through hurricanes. I know people in Central Alabama have been through tornadoes. Other people have been through floods. If you think about a natural disaster and the potential traumatic impact of that natural disaster, I think there's a corollary with COVID-19. And I've taken that sort of asking, maybe are we in a kind of free-floating, ongoing natural disaster? And what's the implication on the trauma that it's going to create in our lives? And I don't have the answer to that. And I think when the book is written on COVID-19 a year from now, 2 years from now, maybe we'll have some understanding about how traumatic this was. What I'm suggesting is if someone had a history of trauma in their life, the impact is going to be that much greater. If there's pre-existing trauma, the possibility of this event being traumatic is also there. So there's your symptoms of grief. Most of us know all of these. Most of these have been, things that we'd see. And so sort of helping older adults sort of, again, we think of grief being associated with death, but I would say grief is a reaction to any loss. And as Bill talked about, I can't see my grandchildren, I can't see my church family, I can't go out as much. What we're talking about is COVID introducing a series of losses. And so I would expect to see these emotional reactions, normal emotional reactions, including cognitive difficulty or difficulty. Early on in COVID, I found myself just kind of getting lost in traffic and doing other stuff. And I thought, man, I've got some kind of early onset cognitive or something. And a colleague, a therapist in town, had a Facebook post of video. She had a video blog, a video log, whatever they're called, on cognitive and COVID. And she was talking about this issue of bereavement, and kind of what she was talking about was, this was probably late March, early April, the anticipatory grief. And that because of the anticipatory grief and this kind of collective grief, she was experiencing patients that were having some cognitive, just not as sharp. And I thought, well, girl, you just told my story. And so just kind of giving everybody a slack. So when we don't know what day it is, your spouse asks, is it Tuesday or Friday? You just kind of say, we've all got a lot going on. So if grief is a set of emotions affiliated with loss, any loss, then I think it's important that we structure older adults on ways to live with grief, live well with grief. The most important, all caps, is just to allow the emotion. Having been a psychotherapist many years, having been in clinical social work nearly 30 years, the place people get stuck, people I see who are stuck in their grief are people that don't allow themselves to feel. So the answer to grief is it won't kill you as long as you allow the feeling to move through you. Just be sad, just be scared, just be angry, whatever the emotion is. There's a wonderful resource. I've got some online resources. There's a book I give everybody I care about who loses a person, and I've got no financial investment in this, but it's a book called It's Okay That You're Not Okay. It's okay that you're not okay. And it just talks about how awful grief is and how long grief takes. And the message is just allow yourself to feel all of it as long as you need to. And so, again, it's not predictable. It's not linear. Most of us who've had a loss understand and can relate to this, and that it's going to be our grieving process. You know, one of the things that happens is people say, well, you need to get on with it. Aren't you over it yet? Again, I think to give our older adults permission to say, it's a drag that I can't go to church. It's a drag that I'm still in the house. It's a drag that I'm staring at these same four walls, and just allow them to express that, to feel that, is the most important thing we can do. Seeking support is central to how people get through it with people that care about us. And so, Bill, you talked about, I can't see my people at church on Wednesday. I've heard lots of people talking about, I'm doing virtual Bible study with people. I'm doing check-in calls with prayer partners and whatever else. And so we've got to, I think, be creative, especially for folks who are being conservative in terms of their physical contact, with what can you do? Well, Mama used to love to go to Sunday school. Let's do a Zoom Sunday school. Or who can you call in your Sunday school? Everybody knows how to operate a phone. Can you get some kind of prayer partner thing going with somebody in your Sunday school? Get 5 or 6 in your Sunday school, and you go and pray and do something. And so being creative about support, particularly in light of the age we're in. Developing self-care plans, working with older adults to say how you're going to care for yourself, physical well-being, emotional well-being, spiritual self-care. Again, interesting. Bill, you talked about the emotional, but also cut off from your spiritual community. I would argue it's a time to build up spiritual practice. Again, if you're used to driving to a place, interacting with certain people, you got to be creative, but there's no reason we can't live our spiritual lives, maybe enhance our spiritual lives, often on webinars. I'm saying to people, what are you doing to take care of yourself? And things like virtual prayer meetings and Zoom support and Zoom church service, all kinds of other ways of expressing a spiritual life, or things I'm hearing from people that are coping well. And then again, grief is different than depression. Grief is something that's transitory, that we move through. Depression is a cloud that comes over and lingers. And so kind of teasing out how long has the sadness been there. Any sadness that's been there that's not related to COVID. But if there's been a sadness more than a year, I think we're talking about depression. I'm talking about a different treatment plan. One of the things we talked about in the planning for this thing was for those of us who've lost family members, or those who are working with people who've lost family members. What are some resources? I always say start with your local hospice agency. I am the hugest fan of hospice. I think if I had to pick one part of healthcare that I've admired the most, it's the people that do the difficult work of hospice. I think most local hospices are going to have some resources, be able to direct you to local resources. Some of those have gone virtual, and so start with your local hospice. Start with local churches and see if there's any grief support ongoing. But what we thought we'd do was talk about just some virtual bereavement. And so these tools exist as I started to research these different ways of finding online support. Again, this would be either for people that are physical distancing and want to keep it that way, can't find resources in the community. And I also want to acknowledge there are some people who just drive into a place, sitting with other people, doesn't feel comfortable yet, and recognizing that there are options available. So underlying behavioral health, I've talked about the emotional needs. Here's what we know, that a bunch of seniors had some emotional needs, significant percent of prevalence, especially for people that are ill. That's not brain surgery. If I don't feel well, that is, I'm not able to care for myself. I got home health care. Another factor, chronic pain. People with chronic pain, it's approaching 25% of people that have chronic pain who report depression. And so depression, anxiety. This other one is really scary. I was doing another workshop on suicide, and what emerges, the most likely people to suicide are older men, and sort of what that means in terms of loss of control and untreated depression. And I would imagine, I don't know the full details of that study, I would imagine access to firearms, in terms of vulnerability to suicide. Men 75 and older have the highest rates than any other demographic group. Pay attention. Addressing grief and allow that. Address isolation and support whatever kind of connectedness. I've talked about multiple different, sit on the porch, sit on the patio. People are doing visits through a screen porch. You're out on the porch and we having a visit. It probably doesn't look like what it used to. In many cases, depending on our underlying health, between mom and daddy's health, the connectedness is looking different. I don't know that that's all bad. I miss being able to drive over to Montgomery and have a good meal with Bill and Rhonda. And for now, it makes sense that we be cautious and keep some distance. Making sure that pain and other complaints are being tended to. Again, if I'm in pain, if there's symptoms of my chronic illness, addressing those problems may lower the depression. You saw rates of depression, if I'm in home health care, are much higher. Rates of depression if I've got chronic untreated pain. So treating my pain, addressing the underlying chronic illness where those symptoms can be mitigated. Older adults less often talk about sadness, and so depression is going to look different in older adults. It talks about, and again, Bill, you were talking about mama's not getting dressed, and what's the reason to do whatever. And older adults are less likely to say, "Oh, I'm sad," but we see change in energy, motivation, and more somatic complaints. And so these are clues to us. Again, think about somebody in their 80s. The language of, "Oh, I feel sad and this must be depression," is not something, but sort of seeing a change in self-care and hygiene. Mama used to get up and do her hair and get dressed, and not doing that. Lower end is saying, "Oh, I just don't have the energy, I just don't feel motivated," or somatic stuff could be a clue to us, more likely a clue. Again, I talked about anxiety as a predictable emotional reaction to COVID. This, what's not known and what's not predictable. Good news is we are pretty clear about transmission, and the only good news I can think of is surface contagion is a little less concerning than we thought early on. But in terms of vulnerability, I just found out yesterday a girlfriend in Seattle has really been kicked in the stomach, and she's guessing that she's down with COVID because the symptoms are all there. So you think you're on top of it. I know her. I know she's been cautious, but something happened, and it happened anyway. So not being in control. I want to acknowledge the cost to people who are still delivering care. Some of us have backed up and we're Zooming with patients. Some of us have, people, all kinds of interaction. And I know there have been healthcare workers on the front line consistently who are there in hospitals, in emergency rooms, in acute care. And so sort of acknowledging that, there's an extra burden to people who've been on the front line this whole time, who've been doing the work, and who've potentially had exposure or have been in places where they're more likely exposed, especially for those of us who are able to shelter at home and be extra cautious, as most of us were.
Hey, Jim?
Yeah.
Hey, I just wanted to elaborate a little bit.
Please.
Here at the health department, a lot of our workers, social workers, nurses, others have been called into this contact tracing. And so, or doing interviews or calling folks to let them know, hey, you had a positive test. And so they're not doing what they normally do. They're doing something different. Yeah. And not only that, when they call, they're finding out and talking with folks that are dealing with COVID-19, potentially have lost a loved one, those kinds of things. And so I think there's a little bit there's a struggle in that. Can I just get back to my old work? And then also, hey, I'm reaching out to these individuals and I'm having the opportunity to hear some of the struggles that they're dealing with, and that's probably very difficult to cope with, I'm sure.
Yeah. You talked about how to deliver bad news, Bill, and I'm sure there are people who are worn down at the end of the day, calling 15, 20, 30 people and saying, well, you better come on down. We think you've been exposed. I think for those folks, what I also hear is, can we just get back to normal? And the answer is, I think everybody is saying, can we get back to normal? Yeah. For those doing partner tracing, I think to just really understand the importance of self-care, of having healthy boundaries, of taking a break as needed. On the one hand, to say we're doing an important public health function of letting people know, but on the other, the burden if we're not mindful, the potential burden, harm to ourselves of hearing people's emotional reaction, anxiety, depression, sadness, loss of control, fear of what could be fatal, all those things, joining people in their anxiety. Again, to have really healthy boundaries and have our own self-care plan in place so that you hang that phone up on the last call. You say, I'm going to go on the porch and get some fresh air. I'm going to walk around the block, or whatever you do. I'm going to eat healthy in the middle of this and not eat, whatever unhealthy things I always go to extra chips and salsa and put some M&Ms on them. So anyway, how we help that anxiety. I've got 2 slides here that talk about the cognitive and behavior. What we know about managing anxiety is what we do with our head, our thinking, our self-talk, trying to be more optimistic, finding our own internal reassurance. And then can we create, instead of, oh, this thing's going to die and it's fatal, it's going to get me. And we all know people who are just wringing their hands. Can you say, likely it's not going to get me. And even if it gets me, I'm going to do the best I can. Can you stop catastrophizing in your head? And part of what I put here is deliberate play on words. Can you change the channel in your own head? And potentially, can you change the channel on the television? We've all got to find our balance of how much information we take in. And one thing I know is that taking in too much information can cause me more anxiety. And so kind of figuring that's the bottom bullet there, manage how much news. There are days I just take a day off. It's like, I'm going to pick up no newspaper. I'm not going to do anything. I was going to say other than Facebook, but Facebook is so volatile now lately, it can get me stirred up too. So sometimes I just take a break and watch dumb video and watch Netflix and try to keep my brain on something else. So in terms of managing anxiety, trying to stay connected, one thought I have in terms of managing the anxiety is doing whatever we can to help others. There's a lot of spiritual talk about how when we're in a spirit of giving, doing for other people, it helps us. And one of the reasons people volunteer, do things at church, secretly drop a pie off at somebody's house, is getting out of ourselves and doing for other people. If anybody on the call lives in Asheville, please drop a pie off on my step. I would love somebody secretly. What if we all just secretly dropped a pie off today? Oh, wait, I'm supposed to talk about exercise, diet, and deep breathing. Again, as we think about good stress management, ways to manage anxiety, eating well, healthy food, staying active in whatever way is safe. I still can't go to the gym. I don't know. I think gyms have opened up in Alabama, but I'm not sure I want to be, I'd want to be a far piece away from people yet. So while we're waiting for things to open up, if nothing else, just 3 deep breaths, 3 slow, deep breaths are your way of sort of introducing a physiological response. Watch that overindulging. Food, funny I didn't put food, my favorite choice. Food, alcohol, shopping, a lot of my wise women staff will tell you that 1 glass of red wine is good for you, but that's 8 ounces and only 1. And so recognizing that anytime we go into the potential for compulsive behavior, I get concerned. Getting enough sleep, and then I talked about managing the TV. Last couple things I wanted to touch on, then we're going to do one more set of questions, is just recognizing this increase in substance misuse among seniors. We've talked about what's here as we talk about COVID-19 and both sort of the increase in emotional, psychosocial stress and what it's like to feel isolated, or maybe what gets a light shown on it as a result of this. If I'd been here 10 years ago, I would have said substance use, fairly steady, not much illicit drug use, alcohol, very little use of opiates. If we fast forward to 2010, this is the SAMHSA guidance. I think this is 2010 data. Rates of substance use among older adults nearly doubled. So there is more substance use. Alcohol use is still the most common. Drug of choice is definitely alcohol, but more long-term opiate use and benzodiazepine use. And that has enormous implications for cognitive and mobility. I talked about the fall risk associated. And then this increase in overall illicit drug use tied to baby boomers. The baby boomers brought their bongs and their whatever, paraphernalia, cocaine habit, something. And so what they think is, again, if I'd been here 20 years ago, I said, no, seniors are not using illicit drugs. We all can think of people, your former brother-in-law who's 60 years old, 70 years old, still smoking pot like a college freshmen, whatever. And so boomers who sort of kept that recreational drug habit going over a period now are people we care about, people that we're providing care for in home care settings or whatever else. I don't know anybody who delivers in-home care that hadn't unexpectedly walked into smell marijuana in the house. Like if you are doing home visits once or twice during a week, you're going to smell some marijuana, regardless of whether your patients are young or old. And so just kind of recognizing that change. 40% of older adults drink on a regular basis. Of these, 1 in 5 has a pattern of risky drinking being more than 7 standard drinks a week. For women, more than 14 standard drinks a week for men. So we got 20% whose alcohol use is problematic, and the stress of COVID-19 and the social isolation. I'm bringing this up. We've got a whole other webinar on substance use, but again, if we're still in a mindset of, I work with older adults, so substance use isn't an issue. I would argue that if we've got 20% that are already risky drinkers, and then we layer all the psychosocial stress of COVID, we got to up our game in terms of screening for substance use problems. And back to Bill's questions, I don't want to call anybody's parents out, but mom and daddy aren't getting up, aren't drinking, aren't doing self-care. I got to ask the question. I'm going to go through their recycling bin and see how many wine bottles are there, just and do some math when I take the recycling out on Sunday and kind of divide the number of wine bottles by the number of days and say, golly, mom and daddy are going through 4 bottles of wine, and when I divide that, that's risky drinking, and maybe I need to intervene. Again, non-medical ED visits, prescription and non-prescription pain pills are why people go, specifically Vicodin, oxycodone, hydrocodone, Vicodin. So if we look at sort of who came, still a small percentage. Let me put it in perspective. We're still talking about alcohol use, but I talked about this use of opiates, benzodiazepines, and this last bullet, people involved with alcohol combined with those other drugs. And so again, just to say antidepressants, some cocaine, some heroin use, some marijuana, and some methamphetamine. So NIAAA just kind of breaks down the likelihood of substance use, and in order, definitely prescription, non-prescription drugs bringing people in, and then finally some illicit substance use. Why be concerned about these increased rates of substance use disorder? Obviously, I've talked about safety stuff, but older bodies and metabolizing substances differently, particularly the benzodiazepines. And so the liver is that organ that filters, and so sort of liver is slowing down. Use of other prescription drugs, that is sort of some use or either alcohol, 40% using alcohol and some prescription drugs. Risk of falls, I talked about unintentional injury. And again, the CDC falls data that says a majority of falls have misuse of medication or medication that shouldn't have been prescribed. I've worked with that group at CDC, and they take a hard line that nobody should be prescribing benzodiazepines to older adults, and many take a pretty hard line to the use of narcotic opiates as being inappropriate for older adults. And then we're not talking about it. We're not screening. We're not thinking about it. It just isn't awareness that older adults could be at risk. And so again, we'll talk more about this in one of the July meetings, but I just wanted to say to just kind of be aware that as we talk about what it's like for older adults, this is a psychiatrist at Johns Hopkins whose specialty is addictive disease with older adults, and just some ideas about how we approach the conversation. Because again, if you are someone that goes to see a patient as a favor, you take their recycling out, and you're seeing a whole bunch of glass bottles. At some point, I think being able to say, I'm gonna step up and at least ask the questions. And so some suggestions here: being non-judgmental, inviting family members into the conversation. If you've got to sign consent and you're a professional caregiver, to say, hey, son or daughter, I noticed when I took Mama's recycling out, there was a whole lot of brown glass in there, and she smelled like last night's beer when I came over. What do you observe? What do you think? And making sure it's a family intervention. Changes in circumstances for older adults is going to increase vulnerability to problematic substance use, retirement, death, things that you'd expect, life changes. Sleep habits, and again, ways in which substance use impacts sleep, or I'm using in order to get to sleep. So if I've got sleep disturbance, somebody's foolish enough to prescribe me Xanax, I get on the cycle where I can't sleep without that. Part of the reason to be non-judgmental is you want that relationship to be there. I was going to say 9 times out of 10, I'm going to say 99 times out of 100, patient going to say, oh, those bottles are here because the handyman came and drank beer, or my nephew came and drank beer, whatever. So I just want to say, you don't want to get in a wrestling match. You want to keep that relationship intact. So you're just going to be matter of fact. You're going to not blow the relationship by getting into a tug of war. You want to listen for requests about prescription medication, and then where it's appropriate, you may want to refer to somebody with a different level to say, we got somebody that helps people dealing with sleep trouble. I probably wouldn't even call it substance use. I just say that's something that helps people with their nerves or with their sleep or with their emotions. Would it be okay if one of my colleagues came by to visit with you? So I'm going to catch my breath. Bill, I know we got some more smart recommendations or hard questions. What have you seen pop up since I was last here?
We do have a couple of questions, Jim. The first one is, what about nursing homes? When do you think family will be able to visit their loved ones in nursing homes here in Alabama and really around the nation?
Oh, Bill, my heart breaks. If I was running a nursing home, it wouldn't be till everybody was vaccinated. I mean, I'd be creative with introducing electronics. I would invite people out on the patio maybe and do some 6 foot, but if I'm running a nursing home, I'm responsible for 80, 90, 150 people. I'm gonna have to say my responsibility to keep in that community, especially when we see what happens. I think of Southwest Georgia. Those of you down in Southeast Alabama know what happened just across the border over in Albany. You look at the map of the United States, there's an enormous outbreak in Albany. That was definitely connected to a whole bunch of care facilities where COVID took off. And so, it breaks my heart. It breaks my heart because, again, I had parents in a facility 4 or 5 years, a facility I loved, and I would have been very concerned if he had relaxed regulations and said, well, we've been at this a while. I think what we don't know, Bill, is when infections really trended down, and we see some trending, but Alabama's got still some really big hot spots, hospital rates still rising. If I'm a nursing home administrator, I'm going to see hospital rates really, really decline. I'm going to see more widespread testing. And a part of me says, until I know family members are vaccinated, I'm not going to have a birthday party in the facility dining room. I can't do it because I got 149 other residents I'm trying to keep alive, and I don't know who's here. I don't know who's coming in.
We've had that same issue here in Alabama in several different places, and even had the National Guard who went in and did some deep cleaning of some of the nursing facilities because of outbreaks. And so, it's a struggle. It's tough, and
it's heartbreaking. It breaks my heart to even say those words. And like I said, how are we going to keep 150 people from getting COVID?
I do have one other comment that came in. You mentioned it a little bit. Elderly folks are passing away, some from COVID, some not from COVID, just because, that's what happens. And so their friends are passing away, and funerals, are very limited. How do you help a senior adult grieve for a friend, somebody maybe they've known for several years, 20 years, 30 years, 50 years? How do you help them, and they can't go to the funeral, and they can't be around folks, and they can't do what we normally do to grieve?
No, another horrible situation. I mean, I think about not being able to see people you care about, not being able to go to the hospital, losing people and not being able to have the service. Horrible reality of this thing. And I don't want people I certainly don't want elderly people in a funeral home with 70, 80, 150 other people. Again, the other part of that outbreak in Albany is there were I understand it, there were a few family funerals where lots of family were there doing what good people do. Good Christian people go to the funeral, and some of those people at the funeral were in fact contracting COVID unknowingly, did go to work in nursing home, and as they've done that investigation in Southwest Georgia. So I just want to acknowledge the horrible nature of those decisions, and to say what we can do is we can do what we do to support people. Tell me, so we can live stream. If there is a funeral, we can live stream it. We certainly have seen that. In terms of allowing people to process their grief, tell me, Grandma, tell me stories about Miss Frances and what you did together. And let's talk about that memory, and write Miss Frances a letter, and let's talk about if she were here, what would you tell her? And just cry the tears and say the words and feel the feelings and try in the best ways we can in the absence of that very important ritual of going to a service and being there with other people who love Miss Frances and eating the sweet potato pie. Please tell me she's going to have a sweet potato pie, Bill, at that party. But that we just can't go. And so being creative in terms of allowing the expression of the grief and acknowledging that it's horrible while acknowledging the cost benefit. In other words, I would say to my mother who lost a friend, Mama, we want to keep you. And I know you want to go be with Miss Frances' people. I know you want to whatever, but we can't risk that. This thing is out here. Here are the hospital rates. Here's the current testing rates. We know people going to be asymptomatic and potentially infectious. Even with a mask, I'm too nervous to let you go. And that cost benefit, again, as we start to come out of our bubble, sort of these questions, and I wish I had definitive answers, but what are current rates of infection? What are the hospital rates? Are we seeing a decline in infection? Have the people, I'm starting to make decisions based on have people I know been doing smart things and been safe, and maybe I'll sit on my front porch with people I know have been making smart choices. Again, I know I'm not going to the mall without a mask. I'm gonna really think through, do I need to go to the mall at all, or can I do it somewhere else? So we're all kind of living with this gray area, cost benefit. But if I've got a senior in a communal thing with a whole bunch of other people, I'm gonna have to say, Mama, I really don't want you to go because we want to keep you here.
And that's all we have at the moment. So,
okay. Well, I'm just going to thank you, Bill, as always, for your clarity and all your good work. I want to thank the guys behind the scenes who do such awesome stuff. Here's my last couple thoughts. I said, is it a trauma? Is it some kind of trauma that we don't yet know about? What I can tell you is here's what people do to survive trauma. People who survive trauma and get through without developing lasting psychosocial harm. Take action where they can. Develop a sense of mastery, finding some spiritual life online, on the phone, talking about what we're going through and seeking help. And we don't know. Part of what I was embarrassed about today is I wish I was some genius who could say, here's exactly what we know. The reality is I don't know anybody that could step in the microphone today and say, here's exactly what we know. There's some things we know. There's a bunch that we don't know. And there's no perfect way to do this. And we listen to gather information, listen to whatever experts. As we think about the needs of seniors, sort of, again, making decisions about what our own parents need, questions about what premorbid psychosocial medical conditions exist, how severe the current situation is where we are, what's their stressful life, and I think real importantly, what have people done to successfully cope with stress in the past? What other tools can they use? I used the phrase earlier, I put this up just so all of us can think about our own plan for care. What are we doing? And as I said, in July, we're going to come back and I'm actually going to have you fill this in. We're going to think about how to take care of ourselves. And I close with a prayer. Not that I've got any answers to nothing, but I do think as I think about sort of how we cope with the enormous uncertainty of COVID-19, I always come back to the Serenity Prayer of Alcoholics Anonymous, Al-Anon, where as we think about how we get through this enormous medical, psychosocial, spiritual challenge, the Serenity Prayer says, grant me the strength to accept the things I cannot change and the courage to change the things I can. I think for all of us, the way to survive is to come to some acceptance about how enormous this thing is, how unfair it is, how challenging it is, and then to take action where we can and change the things we can. Bill, I'm going to go ahead and say thanks again to you. I want to call out my friend Rhonda Holland, the good people doing wise woman work around the state. Ryan and I'm forgetting all the folks. I say, guys, I think it's all male. They're all the people on the video production team who are enormously helpful in terms of pulling these things together. I thank each of you for making time in your busy schedule to take care of this. If you are able to join the other conversations, I welcome it. And Bill, I'm going to turn it over to you to wrap up for us and tell people how they get their credits and do all that other.
Well, first of all, Jim, Rhonda Holland sent in a message. She said, on behalf of Wise Woman, thank you, Jim. As always, you provide us with excellent information. We're looking forward to this series and appreciate you. And with that said, I'm going to go into, this is the first program we're doing on related to COVID-19 on June 24th at 9 a.m., addressing the needs of consumers with substance abuse disorder, SUD, in the age of COVID-19 is our second presentation in this series. We look forward to that. In July on the 8th, intersection of stigma and fear living with HIV in the age of COVID-19, again at 9 a.m. And then on July 22nd, hopefully a kind of a fun presentation, 9 a.m., self-care in the challenging times, care for the caregiver in the age of COVID-19. So we look forward to all of these presentations. We certainly thank James Seiko, Jim, as we know him. He's a consultant to the Department of Public Health. James, we thank you again for all you've done. I want to thank you for being here with us. Thank you for those that are out there watching. Please remember that you can refer back to the training and resources anytime on demand. And just have a great day. Thank you again for joining us. And we'll see you in a couple of weeks.